Bismillah ar-Rahman ar-Rahim. Good afternoon. I think we're going to start our satellite symposium. We're already late by 15 minutes. My dear colleague, welcome to our satellite symposium for the first day. Our satellite symposium today is sponsored by Biopharm Company, and we have two series of lecture at this satellite symposium. I would like to introduce the first speaker. The first speaker for this satellite symposium is Dr. Faisal Sanai. He is well-known consultant hepatologist at our country, and we're so proud to have Dr. Faisal Sanai. He's at King Saud University, actually National Guards Hospital in Jeddah. He's well-known at our research area in viral hepatitis. He is currently advisor for Ministry of Health for viral hepatitis. And today his speech will be about hepatitis C treatment. What is the right treatment duration? Thank you, Faisal, for accepting the invitation. And please, the mic all yours.
Bismillahirrahmanirrahim. Thank you, Muhammad. Ladies and gentlemen, it's an honor to be here. Being given a tall order to talk on what exactly is the right treatment duration for the management of hepatitis C patients. We've got these new DAAs, and that has produced a paradigm shift in the management of hepatitis C. So in the interest of time, I'm going to be focusing only on the available evidence for genotype 1 and 4. These are the two genotypes that are the overall overwhelming majority of our patients here in the country, and that really forms the focus of attention and interest for all of us. So I'm also going to be focusing only or overwhelmingly once again on the studies that have comparisons between shorter and longer durations of time. So I may not be able to present all the available data and literature on these topics, and so forgive me if I'm not going to be speaking on all available clinical trials. Starting off, try to keep it simple. The Osiris trials presented a couple of months back in US. These dealt with the genotype 4 patient with the combination of sofosbuvir and cimipravir. Sofosbuvir is a nucleotide polymerase inhibitor. Cimipravir is a protease inhibitor. So the combination was given in two different groups of patients. One was treatment naive and one was treatment experienced. All of them treatment genotype 4. So they were divided into three arms. One arm was the cirrhotic group, which is the group B, and these were again mixed treatment naive and experienced patients. And the other arm was the group A, which was the non-cirrhotic group, which were randomized into two separate arms again, one receiving 8 weeks of this combination, other one receiving 12 weeks of the combination. And to be noted here that ribavirin is not really included. So about 40 patients in the first arm and this 23 patients in the cirrhotic arm. So these are the results. Basically, if you look at the columns on the right, generally showing you that if the patients were treatment naive, then the response rates with this 8-week regimen was as good as the 12-week regimen and extremely effective, 100% response. And if you look at the last column, what it shows is that the 12-week regimen was very effective in those who were treatment experienced, prior null responders to PEG interferon ribavirin therapy. However, when you gave these patients 8 weeks of this combination, then the response rates were very poor. Basically, if you look at the details of the trial, all the treatment failures were those who were prior null responders. So 8 weeks being generally effective with this combination in treatment naive patients and not being really effective in prior null responders. Now, given the interests of genotype 4 in the region, I'm going to be talking very briefly about this trial that was a French study that looked at about 44 patients with genotype 4, and there were a similar number of patients with genotype 5. I'm not going to be talking about that. So what the results of the study showed was that the combination of sofosbuvir and ledipasvir, which is once again an NS5A inhibitor, the results were showing is that the regimen is extremely effective in genotype 4 patients with a 93% response rate. There were only 3 relapses, and out of that, one was at least a patient who was non-compliant with the medication, but in the interest of the ITT analysis, he was considered as a treatment failure. So the one good study with this particular combination in genotype 4 patients showing that it is highly effective. There is an immense amount of data on genotype 1, and the sofosbuvir ledipasvir combination was evaluated fully in almost 2,000 patients in the ION phase 3 development program. And what this 3 different studies that were done in this particular program showed is that, or at least the distribution of the patients in the different studies was, the ION 1 and the ION 3 had treatment naive patients, and the ION 2 were those who were treatment experienced. The ION 1 and the ION 3 were also including patients who had underlying cirrhosis. The ION 3 is a major area of interest. So what the ION 3 study was, which was in genotype 1 treatment naive non-cirrhotic patients, is that it evaluated the treatment durations of 8 and 12 weeks. 8 weeks with or without ribavirin, and 12 weeks without ribavirin. The ION 1 and 2 once again had genotype 1 treatment naive, treatment experienced, cirrhotic, non-cirrhotic patients, and the regimens tested were 12 weeks versus 24 weeks. So if you look at the results, the bars are generally around the 100% region, or almost 97-98% SVR rates. So extremely effective. Whether you gave them 8 weeks of treatment in the treatment naive non-cirrhotic genotype 1 patients, which you had a response rate of about 94% without ribavirin, and the addition of ribavirin really did not make any difference, or when you gave them the 12 or 24 weeks in those who were either treatment naive or experienced with underlying cirrhosis also. So in these studies, once again, it was demonstrated that 12 weeks of the regimen was extremely effective, particularly in the treatment naive patients without ribavirin. And if you look at the sub-analysis in the treatment experienced patients, 12 weeks of the regimen with the addition of ribavirin was also extremely effective. So 12 weeks basically being almost as good as 24 weeks of treatment, particularly in the cirrhotic patients who were treatment experienced with the addition of ribavirin. So that's a very important point to remember, that you can reduce the treatment duration in the cirrhotic patients also by the addition of ribavirin, and that you can give 8 weeks, an even shorter regimen, with just the fixed 1-pill combination with response rates of about 96%. Now, there was a bit of interest and curiosity about what exactly is the right regimen, 12 weeks, 24 weeks, with ribavirin, without ribavirin, in the cirrhotic patients. So this particular analysis took over all the phase 3 development program of genotype 1 with the combination of sofosbuvir and ledipasvir, and they looked at whether the 12 or the 24-week regimen was more suitable. So what it showed was that the regimens were equally efficacious, particularly in the cirrhotic treatment experienced patients. If you added the ribavirin, then the response rates were almost as good as the 24-week regimen. So basically, once again, showing that the 12 weeks of treatment duration is adequate with this particular regimen. So this is the clinical trial data. What about the real life experience? And we know historically that the real life data has a typical delta, inferior delta of about 5 to 10% in patients who have multiple comorbidities, compliance with treatment, adherence, and so on, and all of these problems occur. So the real life data is very important and relevant to us in our clinical practices. So this is what I really consider as the take-home message as to whether the real life data is equally as comforting as the clinical trial data. So if you look at the target registry data, which comprises of about 1,270 patients who were receiving the combination of sofosbuvir and ledipasvir with or without ribavirin, and if you look at the patient demographics, they have all those nasty caveats which are poor predictive response, including prior treatment experience, cirrhosis, decompensated cirrhosis, liver transplant, HIV co-infection, and everything. So generally being a very, very healthy mix of patients that you really encounter in your clinical practice. So a huge number of patients, and the results very comfortingly showed that the 8 weeks regimen in those patients who were non-cirrhotic, genotype 1 patients with a low viral load or viral load less than 6 million was equally efficacious as a 12-week regimen, both having about 97% SVR rates, and that the extension to even longer periods of 24 weeks really did not make any difference. And what was even more encouraging was that the 12-week regimen in those patients, I presume that these are patients in the red bars who are those who probably were cirrhotic or had other poor predictors of response, and that is why they were given the ribavirin on top. And if you look at the 12-week data, that is equally as good as the 24 weeks data. So once again, 97% response rate. So this is very comforting data from a large clinical trial or large real-life registry. Very interestingly, what the authors of this particular abstract, they showed was, what about those patients who really met the 8-week criteria, basically meaning that genotype 1 patients who have no underlying cirrhosis and who were not previously experienced with any pegylated interferon or any other therapy, and who had a viral load less than 6 million. So what about those patients who met these criteria and did not meet these criteria? And for those who met the criteria, some of the clinicians were treating them with 8 weeks, as the ION 3 study showed, and there were those who were also not very convinced, and they were treating them with 12 weeks. So the results showed that whether you gave this particular subset of patients 8 weeks or 12 weeks, it really did not make any difference. So the results were extremely good, 97% response rates. So just showing that even in the real life data, that the results of the ION 3 studies could be very comfortingly adopted. They also looked at what about on-treatment response. What about the HCV RNA while the patients are receiving treatment at 4 weeks? So whether the positivity or the negativity of the HCV RNA at 4 weeks, did it make any difference? Did it impact on the relapse rate? Did it impact on the virologic failure? And once again, what the lower bars show is that this also does not make any difference. So testing for HCV RNA at 4 weeks did not seem to make any impact on treatment response. Basically, most of these patients, almost all of them, will have an on-treatment response, and therefore monitoring the response while they are on treatment, at least in clinical practice, does not have any value. There was another real-life data, this time from the TRIO real-world cohort, and in this particular slide, it shows the data of 8 or 12 weeks of the treatment in the patients who were treatment-naive, non-cirrhotic genotype 1 patients. Once again, a good number of patients, and what the results showed is that, again, the response rates were equally comforting, 95% overall response rate, whether you gave them 8 weeks of the soft lenipasvir combination or you gave them 12 weeks of the combination with or without ribavirin. So really showing that whether it is genotype 1A, 1B, whatever the range of fibrosis, it really doesn't seem to be making a difference. The bars on the right, for some reasons, some of these patients who were having greater than 6 million HCV RNA viral load, some very few patients also received only 8 weeks of therapy, and comfortingly again, the response rates were just as good as those with less than 6 million. So, moving away from the US into Europe, the Germans showed again their real life data on the genotype 1 non-cirrhotic patients who were treated with 8 weeks, and once again showing that the response rates were extremely good, 100% sustained virologic response. So if you look at these bars, they're all around the 97%. The iron studies showed about 97% in the clinical trial, and if you look at all the other ones, they are just insane. And it's very rare to see real life data matching clinical trial data. So for us clinicians, it's extremely comforting. So you can expect that if you give them the appropriate genotype 1 patients, the non-cirrhotic ones basically, 8 weeks of the soft lenipasvir combination, then the response rates are in the region of about 97%. Now the TRIO registry also dealt with those patients who did not qualify for 8 weeks and they were treated for 12 or 24 weeks, basically those who were cirrhotic as expected and who were treatment experienced patients. So if you look at this, the kind of prior therapy, the treatment experience that they had was with all kinds of different DAs. They were also null responders, which are a nasty group of patients who for some reason continue to harbor a poor prognostic value in terms of treatment outcome, even with the new DAs. So in this, they were given either 12 weeks of the pill without ribavirin, which I don't know why some of the clinicians were doing, and then of course there was those who were receiving 12 weeks of the fixed dose combination with ribavirin, and then there were finally those who were having the fixed dose combination for 24 weeks. And what they wanted to look at was whether it really impacted on the treatment by extending treatment 24 weeks or not, as some have been. So remember, these are cirrhotic genotype 1 patients who were with prior treatment experience, and this huge number of patients, once again, the results are very comforting. So the 12-week combination with the addition of ribavirin, these patients showing response rate of about 96%, but if you look at the actual numbers, they are small number of patients in this particular group. 24 weeks, once again, very good. But this particular combination without ribavirin in these difficult to treat patients, which is the treatment experience and the cirrhotic patients, it is not a good idea to deprive them of ribavirin. So as you can expect, the response rates were rather poor with 12 weeks without the ribavirin arm. This is the Veteran Affairs data. Huge number of patients, 4,365 patients, genotype 1. And they once again looked at 8 weeks versus 12 weeks in patients who met the criteria. And what it showed again is a very good results. Now, my personal inference from this is you're not seeing 97%, 96% response rate for the 8 weeks regimen. And neither are you seeing the same thing with the 12 weeks regimen. And the reason for this, I feel, is if you look historically at the veterans' data, even with the pegylated interferon era, so these patients are really those who have issues about compliance, their adherence is a problem, they have substance abuse, and so their outcome, even with other regimens, including with in the interferon era, is lesser. So if you go into a Veterans Affairs hospital and ask them, I've got a response rate now of about 91, 94%, say this is as good as it can ever get. So this is extremely comforting in the huge number of patients that 8 weeks was just as good as 12 weeks. Moving on to decompensated cirrhosis, genotype 1, and what it showed is in this group of child PUB and C patients, they were once again given the 12 weeks regimen or the 24 weeks regimen, and the outcome once again in this extremely difficult group of patients to treat is that if you give them the 12 weeks with the ribavirin, the response rate is almost as good as the 24 weeks regimen. So really showing that extending treatment to 24 weeks is of no major benefit to the patient. So the response rates are not as good, but they are extremely good for this particular category of patients in which historically we could never treat. And now that we are treating, we are seeing really good response rate. And I've not really shown you slides which showing actually the patients who responded going on to get improvement in the child PU scores, improvement in the MELD scores, and being delisted from transplant registries. What about other treatments? Very few slides on this. We have got the AbbVie regimen with the Turquoise 2 study, which is combination of the paratriprovir, which is a P protease inhibitor, ambitasvir, which is an NS5A inhibitor, and a dasabuvir, which is a non-nucleotide polymerase inhibitor. So what this clinical trial data in genotype 1 patients showed is that once again the regimen is very effective. However, in genotype 1A patients, in those who have underlying cirrhosis, then their response rate are not as good. But in genotype 1B patients, whether they were being treated for 12 weeks or 24 weeks, the response is extremely good, reaching 100% in all the arms. And the ones in genotype 1A, the ones who fared the worst, in which was the real reason for their slightly lesser outcome, was the null responder patients, because these are the ones that historically have been shown to have the poor outcome. So if you look at an 80% with 12 weeks of the regimen with the addition of ribavirin compared to 93% with extension of treatment to 24 weeks. So the general consensus is that when genotype 1A patients who are cirrhotic, then you add the ribavirin and extend the treatment duration to 24 weeks. But in 1B patients, the 12-week regimen is extremely effective. Now, what this particular study did was, in Japanese patients, they went and looked at whether the omission of ribavirin in genotype 1B patients, does it help, or can produce equivalence in terms of the anticipated response rates? And what about if we omit the third drug, that is the dasabuvir, from the regimen? So this is what is known as the 2D regimen, which is the two drug, the paratriprovir and the ambitasvir, without the ribavirin. And what the results showed in these genotype 1B patients is that their response rates are once again extremely good. If you actually look at the treatment naive non-cirrhotic patients, the overall response is about 97%. And in the cirrhotic patients, obviously, the 12-week regimen without the addition of the ribavirin or the dasabuvir cirrhotic group is not really good choice. So probably in the cirrhotic group, you really need to have the dasabuvir on top, which is the third D of the 3D regimen. Finally, in genotype 4, once again, the same regimen of the 2D regimen, the ambitasvir and the paratriprovir. And this was tested in different durations, 12, 16, and 24 weeks. We have data for the 12 and 16 weeks presented a couple of months back in the American meeting. And what it showed was that the 12 weeks regimen was extremely efficacious, and that you reach response rate about 96-97% overall, and that perhaps extension to 16 weeks or 24 weeks is really not required. probably in the next few months, we're going to be having the Merck regimen approved. So the Merck regimen has a combination of a protease inhibitor and a NS5A inhibitor. So I have put the data together and put it in a reanalysis to show whether the 12-week regimen is suitable or extension of 16 or 18 weeks is really required. And what the trial data showed is that in treatment-naive patients who were given 12 weeks without the ribavirin with this particular regimen, the results are satisfactory, reaching a response rate of about 98%. But in the treatment-experienced patients, what you need is the addition of the ribavirin and extension to 16 or 18 weeks of therapy. So if you have a treatment-experienced patient, then not having the ribavirin on board or reducing the duration to 12 weeks is not an appropriate option in these patients. To summarize, ladies and gentlemen, the 8-week regimen of the SOF and SIM combination could be effective, particularly it has to be remembered in non-cirrhotic treatment-naive genotype 4 patients. However, this must be looked at in with the knowledge that the trial had very small number of patients, particularly for treatment-experienced patients where very few patients were included, and bigger trials should be conducted in this particular area. The soft ledipasvir combination of 8 or 12 weeks treatments are extremely efficacious across all the spectrum of genotype 1 infected patients in clinical trial data as well as in real life practice. The 8-week data, even in US, seems to be underutilized, but clearly the regimen really works and the outcome is as good as the clinical trial data. The addition of ribavirin to treatment-experienced cirrhotic patients and decompensated cirrhotic patients may really help to reduce the treatment duration to 12 weeks. And the paratreo, obinutuzumab and ribavirin 12-week regimen in genotype 4 cirrhotic patients is once again highly efficacious. Thank you very much.